Hey guys, aloha, welcome. I'm sorry to be a couple minutes late. We're working on some technical difficulties getting our guest inside. But I want to welcome you guys all for being here on our first pilot HawkTalk Live. My name is Kate Miller, and I am the education coordinator for HawkTalk. Just give us a few minutes and we'll get started on the webinar. Thank you. I see that there are people from all over the country in here, so that's kind of cool. Myself, I'm in San Diego, California. I'm not in Hawaii, despite the aloha and the flower in my hair. I just have this slight obsession with Hawaiian culture and went to college there. I'll just, I guess, talk a little bit about me right now. I am a physical therapist assistant. I graduated a few years ago. I also have my bachelor's in physical therapist assisting. There's only a couple of programs out there, so I'm not sure if any of you have heard of that. I've also been a certified fitness trainer for, 12 years now. I teach anything from Pilates to weightlifting. I train triathletes. I keep myself very, very busy. We are still waiting on our guest. So again, I do apologize. This is a pilot. There's bound to be some kind of jam. I mean, it is webinar jam after all, right? I guess if any of you are in here, we have chat enabled. We have Justine Boss, who is our wonderful marketing director over in corporate, which is actually out of Philadelphia. If you didn't know where HawkTalk is located, our corporate office is right outside of Philly, actually, Conshohocken. If you guys don't know where Conshohocken is or how to say Conshohocken, it's near Philly. Our guest is going to join us in just a few minutes. But if you'd like to chime in with any questions or anything like that, there is chat available. Please let me know if you're wondering about anything, and I'll get to the answers as soon as I can. Something about this webinar, if you share on Facebook, so if you tag us or hashtag HGWebinar, at the end of the webinar itself, we will be giving away some shirts. So once you tag us on that social media, whether it be Twitter and Facebook and Instagram, all of the above, we will get that shirt right out to you. So that's pretty cool. In later episodes, we're also going to be giving some other things away. So stay tuned for those. Hey, Caitlin, thanks for understanding. I appreciate it. This is our first time. Oh, look. Hey, there's Shawn. How you doing? He's not mute, I promise. He can speak. He's actually I'm one of his biggest fans. He was the instructor when I first took the HawkTalk courses, one of them, a couple years ago, and kind of mentored me into becoming a HawkTalk instructor way before I even started working for the company in the position that I am now. Hey! Oh, I can see you, but I can't hear you.
Can you hear me now?
I can!
All right,
Shawn,
good.
you look good, bro. How are you?
I'm doing well. Always fun to be dealing with technology in between patients, right?
I want to thank you so much for being here. He literally cut his day in half to fit in this little webinar, so I promise not to hold you up for too long. I'm so appreciative. So appreciative that you're here. So I told them a little bit about myself. They probably don't want to hear any more of my voice. I don't want to hear my voice. So go ahead and introduce yourself. This is Dr. Shawn Berger. He's going to tell you a little bit about himself, where he works.
Sure. So thank you for the opportunity. So again, you guys have heard my name now. I am a practicing physical therapist in, at this point, Northern California. I have been in primarily outpatient orthopedics for nearly 20 years. But I have cut my teeth in a lot of long-term care settings, LTAC settings, acute care, have kind of been around in a lot of those varieties. But my primary background is in outpatient orthopedics. I have done small clinics with literally, 2 PTs and support staff to running 14 outpatient facilities and ancillary services through skilled nursing contracts and acute care management. So we have had a team at one point of over 400 team members, and so my background comes basically the full spectrum in that regard. As far as our discussion today with Hawk Grips, I have a passion for utilizing manual therapy skills. I come from a Brian Mulligan, Maitland approach, a lot of Dunning's great work with manipulation and so forth, Stu Falzone work with dry needling. But in addition to those excellent techniques, I have been utilizing instrument-assisted techniques for literally my whole career, going back into the early 90s. Probably one of the biggest questions I get all the time is, is this something new? Has this been around? And although our technologies and the systems are evolving, the idea in Western medicine of instrument-assisted technique has been around for quite some time, and I'm proud to say that I've been a part of that for almost the entire period of time.
So basically, in a nutshell, you're amazing.
No. Hey, we're all clinicians, and we all have different skill sets. I say this to people all the time, my coworkers that I work with, that we're all here to try to make people better. And so if we can lean on each other, we can lean on a Kevin Wilk, we can lean on different resources within our community. We're all here to make people better. And I'll tell you, practicing for 20 years, I'm energized for another 15. But I will also tell you, where I have a lot of respect are the clinicians that are entering our workforce that have been in the market for 3 to 5 years, because those clinicians are the ones that are going to be continuing to push me for the next 15 years and are going to drive our industry. So we're all good. We all add value in different roles.
Agreed. And in regards to manual therapy, I think one of the biggest things that sets us apart, and I don't know if you've gotten this question, Shawn, but I have recently, actually. I was asked, what makes me different than a personal trainer as a physical therapist assistant? They said, well, I can go exercise at the gym. I think manual therapy is one thing that really, amongst a lot of other things, education level, et cetera, is something that sets us apart. And I have a lot of respect for clinicians such as yourself that really dive in with their hands and take care of these patients on any end of the spectrum. So when were you first introduced to iStim? Do you remember when? Oh, sure. How?
Yeah, no, absolutely. And I, not trying to single anybody out, but I was actually doing a sports fellowship in Southern California. And it was essentially at the time I was transitioning from an academic into a clinician time period. And the facility that I had the privilege of working at in Southern California was a high volume orthopedic post-surgical facility, and I was excited to be there. So it was a slow day if a therapist in the team didn't evaluate 3 post-op ACLs, and that was a slow day, and that was in conjunction with shoulders and everything else. I mean, it was just a high volume orthopedic clinic. My first day there, the clinicians there were utilizing iStim, instrument-assisted soft tissue mobilization. And it was something that kind of just opened my eyes because I was not introduced to it in my academic setting. I was like, wow. And so that was my first literally experience, was actually through ourselves, through our colleagues, to say, wow, what is this? To be able to utilize something as an adjunct to our hands to try to make a positive difference. That's what got the bug going for me. And what I always share with clinicians all the time, instruments and the idea of utilizing tools to augment our soft tissue, they're not to replace our hands. They're to facilitate our hands to be better. For reasons that I'm not able to explain fully, our nursing colleagues, our physician colleagues are not intimidated by utilizing tools. For example, stethoscopes, otoscopes, these type of things that are designed to enhance senses of looking into someone's ear or evaluating breathing or things of that nature. And yet for a lot of clinicians, whether it's physical therapists, chiropractors, massage therapists, we sometimes, and I don't want to say always, sometimes we tend to think of our hands as the be all end all. And I always tell people right off the bat, I love manual therapy. I think our hands have an opportunity to make valuable changes for patients and improve patients' lives. But for me, the excitement is being able to take a tool that can leverage that we can create and change tissue dysfunctions in a leveraged ability that excites me.
No, I agree. I think that's probably one of the best analogies I've ever heard, actually. When did you start? When were you familiarized with Hawk Grips? Who approached you? Who'd you meet first?
Sure. So different people hear different stories. There's a lot of stories out there of where things originated from. I always tell patients that the idea of instrument assisted or instrument augmented soft tissue has honestly been around for thousands of years. But those clinicians like ourselves that have been practicing over the last 20 know that there are different brands and different things that are out on the marketplace. I had actually been a long-term instructor. I am passionate about making differences for patients. So I had learned under the tutelage of Doctors Tom Hyde, Greg Dorr, some of these people that were instrumental in the beginnings of some of the techniques that are out in the marketplace, other brands. And I began teaching. And so I taught for literally over a decade, multiple weekends to thousands of clinicians, and had the opportunity to meet and learn from them, and maybe offer some small bits of advice, and maybe we could help our practices out. For Hawk Grips specifically, I had been involved with and also under the tutelage of Dr. Phil Page. And Phil Page, who is the Director of Clinical Research and Education for Performance Health. Some people are familiar with some of their brands like TheraBand, BioFreeze, things of that nature. He was familiar with my background, both in the technique of instrument assisted, but also in the role of teaching. And he asked and basically came in and introduced me to the principles at Hawk Grips, and allowed us to continue the dialogue. And as I told the owner of Hawk Grips in our early conversations, is that I'm a champion for anything that makes patients better. And if we can find tools and techniques to make our patients better, that's what excites me.
That's awesome. That's a way better story than mine. I became introduced to Hawk Grips. I don't know if I ever told you this story, but I was a student as well. Mm-hmm. And I was at the CPTA conference. I believe it was in either Oakland or Pasadena, somewhere not where I am down here. And until about maybe late last year, I thought I had met Shawn, who is one of the employees here, one of the higher employees here at Hawk Grips. I actually met Frank, the CEO, the owner.
Sure.
And it was just really cool to see somebody so passionate about helping people. I wanted to do the same thing. I wanted to change patient lives. I was still a student wanting to essentially change the world. And I saw that, the benefits of iStim while I was in one of my clinical rotations, and saw Hawk Grips again at a conference and fell in love, basically. And here I am.
Sure.
Speaking of funny stories, do you have any funny stories? I know you do. In regards to Hawk Grips, your experience with Hawk Grips, any kind of stories that may stand out?
You think about these things. At the end of the day, what are Hawk Grips? They are metal tools to facilitate or augment soft tissue, and essentially we come in with different approaches of utilizing our hand skills. I think every clinician has a story, good and bad. We tend to, once someone told me that we trade these stories like baseball cards, like kids trade baseball cards. Hey, I had this and you have this. But you know what? It gives us an opportunity to learn. And anytime we can learn, we improve as clinicians. We've all had, in any technique, we've all had these kind of stories. I'll just tell you one quick funny story with Hawk Grips was, I actually was working out of my yard on an off day and got sunburned pretty significantly. And I thought, boy, what an opportunity to understand the role of proprioception, neuro adaptation, afferent stimulus. What would happen here if we Hawk Grip a sunburned area? And so I thought, here's this perfect opportunity because I have one arm to treat, I have another arm to control, and I thought this is great. And so I took one of the instruments and effectively did instrumentation, but effectively dry shaved one complete arm. And as you can imagine what that would feel like. It hurt, but at the same time, I learned something, and that's the opportunity of learning. And that is, after that we did that, immediately afterwards, I had no more sensation of the sunburn, meaning I had no more forearm tightness if I would try to flex the wrist. The sunburn didn't disappear, but we had affected the nerve system. So by taking that instrument and rubbing it across the sunburn, we had desensitized it and so forth. I've shared this with a number of colleagues who work primarily in neuro, and we utilized that case study or that example to say, hey, maybe we can do more than just break up a lesion. Maybe it's just something more than just doing cross friction. And so the simple answer to that story, although it's somewhat funny, is that I had an opportunity to be sunburned, and I said, hey, let's do this. And we found something out of that. We found that we could actually take away and remove the pain. So we were playing around with afferent stimulus. So I think for those clinicians who are in like neurobase, It's not about us saying, oh, I have, this trigger point here, I want to work out, let's just work a piece of metal there. That's not what hot grips is about, or any instrumented technique. It's looking at it and saying, what are we trying to do? And there's typically 4 theories that have been to some degree researched, some researched much more than others, but some that are still more practicing theories of how instrument-assisted techniques work. One of them is basically the idea of cross-friction or mechanical load, and this is where we would basically find a lesion and break it up. Stimulus of knowing where they are in space, basically close chaining themselves into that area and doing that. And so the idea of neurological input. The third area of theory is the idea that we can basically create fluid exchange. So lymphedema therapists or therapists that are working in an acute care setting can actually utilize instruments, and this might be something for a live seminar in the future of actually doing some demonstration of this, but we can actually push and move the fluid and utilize a tool as a leverage tool for our hands. And then the fourth theory, so we have mechanical, neurological, and fluid exchange, but the fourth main theory of instrumentation is the idea of what we call the fascial theory, sometimes referred to as the mechanical transduction theory. And that is the fact that we can treat, for example, the plantar fascia and relieve knee pain, or maybe treat the plantar fasciopathy or plantar fascia and relieve low back pain. And so these can't be explained by traditional modes of, let's say, breaking down scar tissue per se, but the idea of fascial theories or the idea that we can release that. So those people that ultimately decide to get interested in instrument assisted, whether they take a course or they do more online training, basically are going to be funneled back into those 4 main theories: the idea of fluid exchange, the idea of breaking up scar tissue, the idea of kind of a fascial theory, and then lastly, the idea of kind of a neurological theory.
So everything you said, awesome. What do you have to say to people that think that they can just grab a spoon? I had somebody the other day, so I could just use a spoon at home and just do it myself. I think that's more towards gua sha, where all of this came from, as you mentioned earlier. But what would you have to say to clinicians who say, I can just buy instruments and do it myself?
Sure. It's a slippery slope. I smile when you say that, because I actually have been known to tell patients to use a number 2 pencil, the convexity of that to cross friction their own patellar tendon, for example.
Like how Graston was created.
Yeah. So I have been known to do that. Here's what I would tell clinicians. I think that there's a difference between sometimes what patients are doing. No one expects a patient to go out and buy their own set of instruments. We might expect them to go out and buy, let's say, a tiger tail or a TheraBand roller or some sort of mechanical device, a foam roll to do rolling. But no one expects that from a patient standpoint. But I will tell you, from a clinician standpoint, we have invested, and I don't mean to belittle our profession, but we've invested hundreds of thousands of dollars into our education. What comes along with that is the role of responsibility, professionalism, and so forth. And I think that clinicians, and this is my quick answer to that question, is I think clinicians run a very, very slippery slope if they are utilizing any instrument or tool that has not been made and manufactured for the purpose that they're utilizing it. So if I utilize a spoon on somebody, can I create a change? Candidly, yes, I think I can. But if that patient complains, if that case becomes litigious for whatever reason, boy, do I caution clinicians. How do you respond when someone says, what training did you do? Oh, I just took a 10-minute webinar and learned how to do it. Oh, I see. And what instrument did you use? What professional instrument did you use? Oh, well, I used a soup spoon, or I used a $10 thing I bought on Amazon. Quite honestly, I think any clinician like that is going to get chewed up in a litigious situation, and it won't be pretty. So I think that I think people just need to understand that we aren't out at home manufacturing our own ultrasound machines. Everything that we do has a professional load and responsibility. So I think in the big picture, listen, I've been doing instrument assisted for 20 years. I have purchased no less than a dozen sets that I've purchased for full retail. Because I put them in other clinics and with other colleagues. I know the investment into them, but I've also purchased, I'm not exaggerating, 40 ultrasound machines. I've never lost sleep over purchasing 40 ultrasound machines. I've purchased a number of other equipment. So I just look at them as simply a capital cost that goes back into your clinic, and it is part of the process of providing that level of service that you want to do.
I agree. It's a kind of really, really good way to put it. I want to open up the floor, since I don't want to take up too much of your time. I'm so grateful that you came to talk to us today. To anybody that may have any questions for Shawn, before he goes back to being the busy clinician that he is. I'm not sure.
I'll just share. I mean, I just popped in here between a couple, patients, and I'm happy to do that. But, we're doing manual therapy, probably 80% of our patients. Of those, at least 80% of those were utilizing instruments on us. And so I think, helping people understand, one of the questions I get a lot is, when do you use the instruments? And I always answer it the same way. When you can make a clinical decision to use your hands, you can utilize the instruments. And that includes both preoperatively, postoperatively, or non-surgical. If you can make a decision to use your hands, you can alter the mode. What about the actual application itself? Do we do it? How long do we do it? Where do we do it? These are things that we would teach, that people would learn in a class, that we would teach in a class. But I think it's helpful for people to understand that anytime you can utilize your hands, you can utilize an instrument. And then the why. Well, why would I want to do that? The reality is that we're driving force from a broad surface, our hands, into a more specific surface. That's the key to instrumentation. We're able to draw that force in a more specific area, and we're able to drive outcomes a lot more efficiently. So I'm happy to answer questions on that, but I think that it's just, we're planting seeds just to have people consider, hey, how do we, what are some other tools in our bag, no pun intended, but how do we make patients better?
So we do have a couple of questions, actually. I'm not sure if you can see the chat. I'll read them to you. So
Sure.
What kind of feedback do you hear from patients about receiving HawkTalk treatment?
So typically we'll see, I kind of tend to see two different types of feedback. I see feedback from patients who have some experience into these modes of application. Maybe they've had a different brand or something of that nature, and they're very receptive. They're the ones that are, kind of, maybe if I can use the word CrossFit mentality, or a little bit more athletic or gym rat mentality, and they're coming in kind of asking for that. They know what to expect. Then, quite frankly, the vast majority of patients we deal with in our clinic, I mean, I'm in a clinic now, it's an outpatient orthopedic, I call it 8 to 80. We do a little bit of everything. The vast majority of our patients have never seen it before. So what we do successfully, or try to encourage others to do, is we introduce it actually during the eval. So when we're doing the evaluation and someone is responding, saying, you know what, I have tenderness, let's say on the anterior aspect of the shoulder, we'll bring the instrumentation in as part of the assessment. And that's when we'll get the question. We'll say, well, what is that? What are we doing? And we'll explain to them that this gives us the opportunity just to assess this a little bit differently. And it also then, right then in the first session, allows us to transition from an assessment stroke, maybe a light kind of sweeping stroke, into, oh, I identify something there, let's go ahead and treat it, and go right into treating. And so by transitioning the instruments in the eval, quite honestly, that question almost is answered a little bit differently. We're just basically saying it's an assessment tool that transitions into a treatment tool.
No, I think that's great. I've never actually heard somebody do it during an eval, but I mean, what people may not realize is these tools they don't just treat, they can diagnose as well. So it's a very, very good point. Another question, has iStim had a positive impact on your clinic profitability?
So, well, that's an interesting question, right? That's what a lot of people want to ask. I'm going to answer it this way. It allows clinicians, if they choose to, it's a mindset, to be a lot more efficient. So I am not having to do a 20-minute manual soft tissue release for a chronic plantar fasciopathy by releasing the gastroc and the soleus and the tibialis anterior. Think about if I had to spend with my hands even 3 to 4 minutes on each of those compartments, posterior, lateral, anterior compartment of the leg. Then you go down, maybe you're doing some mobilizations of the saddle joint, or the in the foot, and then you go in and do another 3 or 4 minutes of releasing the plantar fascia. That's a 14-15-minute heavy manual treatment. Now with instrumentation, I can knock that down to 5-6 minutes max. So, and the patient is feeling more engaged. Plantar fasciopathy is a great example. Where is the position of provocation for that? It's standing and walking, right? And yet so many clinicians treat their patients prone on a table with their foot hanging off. It's not functional. I've never had a patient say, boy, my foot hurts in prone, right? So the other thing is we treat all of our plantar fasciopathy standing and walking. We'll get them loaded where they're doing heel raises and actually take the instruments underneath the arch and actually roll the arch during weight bearing. That does two things. It speeds up application and it gets patient buy-in. So I'm coming full circle to the question, how does it affect profitability? It's allowed us, again, if you can choose to do this, it allows us to be more efficient with time, and therefore we're getting more patients in. Typical day for me, I'm seeing 20 to 25 patients in a day. And that's going to vary across the country. But that's where I'm comfortable, and then still trying to find time to break and doing those other things. The other thing is on patient engagement. There's something very unique about manual therapy, and instrument assisted augments that even more, where you get more patient buy-in. They're like, wow, that was it. That's what I want to. That you're actually treating what I want to do. And so when we finish that answering that question on profitability, in our practice, we're able to be more efficient and see people much more frequently, more on a faster schedule. And then our cancellation no-show rate is consistently under 5%. Awesome. So if you look at national averages that are 8 to 12, depending on how those are asked, I believe that part of that is that we have more patient engagement. And so with that affects profitability on the back end because they're not canceling and no-showing.
That, and I mean, I can't tell you how many patients I've actually had fall asleep on the table when I'm trying to perform manual therapy.
Man. You gotta push harder then.
The geriatrics I worked with, I can't go too hard, I'll break them. But no, I think that's a very solid point. We probably have time for maybe one more quick question. It's kind of, I'll combine the two questions. Thank you for everybody chiming in, by the way. Do you combine iStim with any kind of resistance or stability training? And do you have any guidelines on dosage? Now, before I have you answer, I think that a lot of these things can be answered in classes. This is kind of some of the information that you learn when you take courses, any iStim course, but especially HawkTalk.
Sure.
So how would you?
Yeah, I smile because that's where my passion is. And so I mentioned earlier my tutelage under Greg Dorr and Tom Hyde, who are just phenomenal clinicians, more on the East Coast. But they were really the two clinicians that pioneered the term or the concept of treating in the position of provocation. So as I just alluded to with my plantar fasciopathies, I will always treat them standing. Almost with every treatment. If someone's shoulder is hurting when they reach back in the car, it's that motion, that horizontal abduction, maybe that impingement that's occurring. I'm going to ultimately want to treat in that position. My neck hurts when I'm going into extension. I'm going to look to treat in those positions. And so coming back to that answer, what we learn or can progress to as your skill sets with instrumentation is understanding that anywhere you can use your hands, you can use instruments. And so the answer is, if you treat now doing manual therapy, if you do active release technique, if you do a pin and stretch or something like that, we can do similar techniques with instrument assisted. And so the simple answer is yes. Almost all of our skill and care, or I should say our care with instrument assisted, is done in positions of provocation, in weight bearing, in functional activities. If someone has snapping lateral hip symptoms while they're riding their bike, guess what? We're going to put them on the bike. And as they're pedaling, we are going to be doing instrument assisted on that because we're going to try to clean up some of those restrictions. So I would hope that, if we can plant a seed, is that there's great opportunities there. You don't just have to treat statically. You can treat dynamically, and you can treat with resistance. You can treat with, doing squats and lunges and things of that nature. So to answer your question, yes, puts a smile on my face because it gets me excited. When we are teaching HawkTalk courses, it can be overwhelming for some people to try to get that far in a one-day course. But this is why a lot of courses out there are set up into one-day and two-day courses, is that we can learn the basics in one day and then try to advance our skills as we go forward. But the simple answer to your question is yes. Treating loaded, weight-bearing, and position of provocation is where we see our best outcomes.
Awesome. I appreciate it. I'm sorry for the noise. My dogs are apparently excited about everything you have to say as well.
Oh, man.
So that's the noise that you all are hearing in the background. But Shawn, I just want to say thank you so much for coming on this pilot episode in the middle of your day, for scrambling with the technology. We're all this is a learning process for us here as well. So thank you so much. And if anybody has any questions, please feel free to forward them to me. I can forward them to Shawn. And we hope to see you guys again. Remember, if you post about this webinar, if you share this webinar, hashtag, tag, tweet, all that stuff, you will win a shirt. And we'll have many more things to give away in the future. So please join us next time, same place, in my kitchen with the next guest.
All right. Thank you, guys.
All right. Take care, everybody.